Hi, Dr. Bertelsmann here. I have Linda with me. Linda came in this morning with an interesting history. She was out bicycling with a group of friends on one of our local trails, and it started to rain, and Linda was going down a steep hill with a pretty good embankment, and her tires slid out from underneath her. Linda hit on her buttock, on her left buttock, and there's a tremendous amount of bruising, and now over the last couple of days that bruising has moved around and is kind of migrating downward via gravity. The good news is that with an x-ray of that area through her primary care physician, there was nothing broken in the hip, and Linda really doesn't have any hip or even lower back complaints. But what Linda does have is some pain in her mid-thoracic area now, and that's what she came in with. She stated that it started right after the accident. It was a constant dull discomfort, becomes sharp with movement. Linda really doesn't like to take a deep breath and doesn't like to bend forward. Those things are particularly uncomfortable. Most movement in general. So we took a look, and I wanted to answer two questions. Number one, what's the diagnosis? And number two, is the tool that I use every day, manipulation, appropriate for Linda? Is it something that's good? So when we looked at Linda, I was able to palpate her back, and it really wasn't tender in the buttock or the hip. It was tender in the mid-thoracic area, over the top of the rib, really the seventh costovertebral junction. And Linda's pain was more on the left, and when I compressed Linda's rib, she has a little discomfort with that as well. So rib compression, tenderness over the costovertebral junction. We know that there's some rib restriction there. The thing that concerned me is that when I had Linda lie down on her back for some of the orthopedic testing, she said that was really uncomfortable and didn't like lying on her back, didn't like transitioning back and forth. So we take a little closer look, and when I do a bump test, Linda, is it okay if I bump your back again?
Yes.
So when I do the bump, you can see that there's some tenderness over that T7. When we bump lower, really a little tender, but then I can hit pretty hard down low and no trouble. When I take a spinous process and tap it, I can kind of isolate that when I come down to T7, that's where she reports the most tenderness. And then the other sign that concerned me with Linda is Linda, if you could stand back up. And you can see that Linda moves guardedly, and typically she's very active, very athletic movement. So she's moving guarded now. And Linda, if you could come up onto your tippy toes as far as you can, and now drop down. And you see the grunt, the groan, the pain that's with that. So a positive heel drop test. So now we have a positive supine sign, a positive heel drop test, and a positive seated closed fist percussion. I'm certain that Linda has a compression fracture in the T7 area. We'll get some films of the area. Her primary already has films of the rib, so we'll determine what needs to happen from that point. But now we know that Linda's not a candidate for manipulation. She has something else going on, and so we'll address that in a different way. Thanks for watching. Alright, so we received Linda's films back that she went out for, and it shows what we suspected. I'll let you take a look at this. It shows an osteoporotic vertebral compression fracture. Sometimes subtle deformities can't be appreciated radiographically, but obviously this one can, as most others do. What we see is a wedge-shaped deformity where there's a loss of the anterior vertebral body height, but the posterior columns and the posterior vertebral body is pretty well preserved. We also want to make sure we're screening for signs of more significant or ominous pathology, something like intrapedicular widening or collapse of the posterior elements where it looks more like a pancake. That would be more significant. So obviously now Linda is not a candidate for high velocity manipulation. We're going to look for low force alternatives for that costovertebral dysfunction. We especially want to avoid compression or axial loading of the vertebra and deflection. We're also going to send that patient out for any appropriate treatment. If you'd like to know what the best practice management is for this condition, check into the ChiroUp protocol. ChiroUp's a knowledge transfer, and more than anything, we'd be interested in how you'd manage this case, because it's not a one-way street. We want your input as well as to redefine the standard of care for the patients that present to our office. I hope this was helpful information. We'll look forward to speaking again soon. Thanks.